Welcome back everybody, David here again with Med School Bootcamp. So in this next video, we are going to talk about the high-yield renal anatomy that you need to know to get questions right on test day. And so remember, when we talk about the renal system or the kidneys, we're talking about two retroperitoneal structures that are located approximately at the 11th and 12th ribs. And while the exam is mostly going to focus on the pathology of renal problems, it will ask you some basic anatomy questions that they'd like you to know. So if we start thinking about the anatomy here, we can break it up into two key parts, the renal cortex and the renal medulla. The renal cortex includes things like the glomerulus, the proximal convoluted tubule or PCT, the distal convoluted tubule or DCT, and the cortical collecting duct. Some of the major structures in the renal medulla include the renal pyramids, renal columns, loop of Henle, and the medullary collecting duct. So if you draw your attention to this image over here, we can kind of zoom in on it and take a closer look. So here you can see some of the major structures that we talked about. The renal cortex is essentially this outer portion of the kidney, right? It's the cortex, if you will. Now, when we talk about the renal medulla, we're talking about a section that is the deeper portions of the kidney itself, from the renal cortex, which we said is this outer layer right here, up to some other structures called the calyces, which ultimately go to be the renal pelvis. Some other macroscopic structures we look at is this kind of triangle appearing structure, which is composed of three main parts. It's the renal pyramid. The whole thing is called the renal pyramid. Why is it a pyramid? Again, because it's a triangle structure. We have the renal papilla, which is really just the portion or the tip of the pyramid, if you will, of the structure, and the renal columns, which is this area that's actually between the renal pyramids. So again, we have the renal pyramids. It's kind of this triangular shape. The tip of the pyramid is called the papilla, which is up here, and then we have the columns, which is this area that is in between the renal pyramids and the renal papilla itself. Other important structures to know include the renal artery, which brings blood to the kidney, and the renal vein, which ultimately brings blood away from the kidney. We're going to talk about some microscopic structures next, but this is kind of a general overview of the main macroscopic structures that they'd like you to know. Now, when we talk about the arterial supply, there's a lot of structures they want you to know here. And while in theory it would be good to memorize all of these anatomic structures, I'm going to highlight the ones that I really want you to know because they're more commonly tested about. And so these include things like the renal artery, the afferent arteriole, the efferent arteriole, the peritubular capillary / vasa recta, and the renal vein. Now, some other important structures that I didn't highlight include the glomerulus, which is where the afferent arteriole actually enters and the efferent arteriole actually leaves. This is also a very important structure as well. In addition to these vascular structures, you also need to kind of have an idea of where the glomerulus is in relation to these structures. So the afferent arteriole is going to go into the glomerulus, often remembering that the A stands for arrives, or it arrives to the glomerulus, and the efferent arteriole is going to leave the glomerulus, or it is going to exit. So again, memory aid here, A, afferent arteriole arrives at the glomerulus, and E of the efferent arteriole exits the glomerulus. And so if we take a closer look at this image over here, we can see really nice illustrations of a lot of these structures that we talked about. So again, the renal artery goes into the kidney itself. Then it kind of breaks up into smaller vascular structures, including the segmental artery, the interlobar artery, the arcuate artery, the interlobular artery, ultimately coming to this high yield structure we talked about, the afferent arteriole. Now the afferent arteriole, remember A stands for arrive, goes into the glomerulus, and that's what we see here. This is the glomerulus, and this whole structure right here includes Bowman's capsule and the glomerulus. Ultimately, blood is filtered right here and goes through a lot of these other sections, which make up the nephron itself. So up here we have kind of the proximal convoluted tubule, we have the loop of Henle, we have the distal convoluted tubule, and then ultimately we'd have the collecting duct, which is actually where urine will go and then ultimately be excreted from the body itself. A lot more on that in the physiology sections, and particularly in the pharmacology sections where we talk about all kinds of medications that we can give that act at various portions of the nephron itself. But as you can see, once blood leaves the glomerulus, it goes through the efferent arteriole. We said the E stands for exit, ultimately making its way to the peritubular capillaries. And again, in some of our physiology videos, we'll talk about the effects of this as far as a countercurrent exchanger and why this is super important in physiology for us to understand. But for now, I just want us to understand the basic anatomy. Ultimately, the blood is going to leave through similar structures on the venous side and finally make its way out of the kidney through the renal vein. Now, another very high yield structure that they want you to know because they will ask you test questions about includes the JG apparatus, or the juxtaglomerular apparatus. Key structures here include the macula densa, the juxtaglomerular cells, sometimes called the JG cells, and the mesangial cells as well. So if we draw our attention over here to this image, we can see a really nice illustration of this structure that shows all the high yield things that we just previously talked about. Again, to orient ourselves, we have the afferent arteriole, blood going into the glomerulus itself. This would be the efferent arteriole, the proximal convoluted tubule we talked about in the previous slide. And then we have this area where the macula densa and the JG cells, or the juxtaglomerular cells, actually work in the kidney. So what do? What is their function? Well, the macula densa is composed of cuboidal cells, which is located at the distal end of the loop of Henle, as well as in the DCT, or distal convoluted tubule. And its primary role is to sense sodium chloride concentration in the body. it then responds by potentially activating the renin-angiotensin-aldosterone system. We have a whole video about that. We'll talk about the details of that physiology, which is super high yield. But essentially, if this system senses low sodium chloride levels or low salt in the body, it's going to activate the renin-angiotensin-aldosterone system to bring back more sodium. So if this system right here senses low sodium chloride, it's going to respond by increasing renin released from the body. And more renin is going to act to bring back more of that sodium chloride, ultimately bringing back more water as well and increasing the patient's volume status. And so while the macula densa is the sensing system for this, it's the juxtaglomerular cells that actually synthesizes the renin and allows it to be excreted from the cells. And sometimes these two components together is called the juxtaglomerular complex or the juxtaglomerular apparatus. And finally, there is a third type of cell called mesangial cells, less commonly asked about. Mainly these cells just remove some debris from the body. But the two I really want you to know and focus on are the macula densa and the juxtaglomerular cells. Now, finally, to wrap up this video, we're going to talk about some additional structures. First, I want to draw your attention to this image over here, which is a CT scan. Recall, we said these are primarily retroperitoneal organs. And so when you look at this scan right here, you can orient yourself, right? This is going to be the right side because we're looking at things opposite of what we'd expect to look at. We're assuming that we're looking at the image through the patient's feet, so things are kind of flipped over. We have the liver over here, and then we have these two structures right here in the back, these retroperitoneal structures, which are going to be the kidneys. And again, it's important to appreciate what normal looks like, because what happens if they give you an image and the kidneys all of a sudden has this giant mass over here? Maybe they want you to recognize that there's a tumor involved. And so again, it's important to look at this image and say, okay, here's a nice, normal appearing kidney bilaterally. Well, if this looks unusual or if these things look different from one another, right? If they give you an image and there's an obvious difference between the two, this is indicative of a possible pathology. Now, some key anatomy that I'd like you to know includes the left renal vein being longer than the right renal vein, also knowing that it drains the left gonadal vein, and this is different than the right gonadal vein. So if we now draw our attention over here to this image, we can see the aorta and the venous system. Now, what's interesting is that the drainage system for the gonads is different. And so anatomically, the right gonadal vein, whether that's a testicular vein or an ovarian vein, drains directly into the venous system, ultimately making its way up to the inferior vena cava and back to the heart. But on the left side, that's not what we see. Here, the gonadal vein is going to drain from the gonadal area into the left renal vein. This is then going to make its way to the inferior vena cava and back to the heart. So there's a difference in the path of blood back to the system. And this is really important. They like to ask you about this with anatomy questions, particularly talking about compressions of various veins. They might also talk about metastases of cancer from the gonads. And you can appreciate that the answer is going to be different whether they're talking about the right-sided system or the left-sided system. The flow of blood back to the heart takes different paths. It goes through different structures. And so again, that becomes a high yield thing that a lot of students are unaware of and they get confused of. We need to know that the left renal vein is longer than the right renal vein. And we also need to know that the blood flow or the blood drainage from the gonads follows a different path depending on if it's on the right or left side. Additionally, they also like to ask about nutcracker syndrome, which is compression of the left renal vein by the superior mesenteric artery. This can present in a patient with abdominal pain, hematuria, or varicocele. So what is nutcracker syndrome? So if we draw our attention back to our image here, we can imagine that if we have another structure that's not shown here called the SMA or the superior mesenteric artery, it actually runs right above the left renal vein. And what can happen is this structure right here can actually compress the renal vein at times. The classic way this presents is a patient who loses weight rapidly. Rapid weight loss ultimately leaves less of a buffer between these two structures because some of that abdominal fat that's kind of expanding the structures and not allowing them to compress. The body's a little bit more bloated. Once it becomes smaller and smaller, these veins can actually compress on each other. And so now this overlapping arterial structure is actually compressing the vein at this area. What's going to happen? We're going to get a backup of blood into the kidney, and this is why it can present as hematuria. Some of that blood can actually be found in the urine as well. Patients are also going to have abdominal pain. Why? Again, because they have a backup or congestion of blood into the kidney itself. And so this is called nutcracker syndrome. They really like you to understand this anatomy, that the superior mesenteric artery runs over the left renal vein. And so this is a way that a patient can have a pathology based on purely normal anatomic structures. They also like you to know about the relation of the ureters relative to the vas deferens or the uterine artery, and that the ureters run under the vas deferens and uterine artery and over the common iliac artery. This is sometimes remembered with the phrase water under the bridge. And so if we look closely at this image right here, we see the ureter, which has urine or the water in our water under the bridge saying, goes under the uterine artery in females and under the vas deferens in males. And so this is where we get this water under the bridge. the bridge being the uterine artery or the vas deferens. And why does this matter? Well, anatomically, it's really important in surgery, particularly gynecologic surgeries. And that's how they like to ask this question, is that complications can occur and that we can have damage to the ureter during gynecologic procedures due to the close proximity of the two structures together. Again, these structures are really close together. So if we're needing to ligate the uterine artery during a gynecologic procedure, the close proximity of the ureter makes it so that complication can occur that you can actually nick the ureter by accident, which would lead to a leakage of urine from the system. And so that's one thing I'd like to ask you about. And really it just entails knowing the anatomy, knowing the structures and which ones are proximal to other ones. And thus anytime we are doing an intervention, a surgical intervention, structures that are close together can obviously be damaged during the surgery, even if it's not intended. Finally, to wrap up this video, let's talk about some basic anatomy, including the bladder, the ureteral orifice or the trigone, the internal urethral sphincter, which is under involuntary control, the external urethral sphincter, which is under voluntary control. We have a whole video about that later on in the section. We'll break down the specific nerves that are involved and the nerve plexuses that we need to know for test day. But the point here is that we have both involuntary and voluntary control of our bladder system. And also we have the autonomic control of our detrusor muscle. So if you draw your attention to this image down here, we can see this important anatomy. We have the ureter we've talked about. This is the peritoneum. So above this is essentially the abdominal cavity. We have the detrusor muscle, which helps contract the bladder as we're going to the bathroom. It helps squeeze the urine out of the bladder. We have the ureteral openings. So again, the ureters actually anatomically go behind this system and actually go into here. And then we have those two sphincters that we talked about, the internal urethral sphincter and the external urethral sphincter. Also important to note from a histologic perspective that the bladder is composed of transitional epithelium. And that's important, right? So when we talk about epithelium and say the tubules or the lungs or other parts of the body, we talk about, oh, it's simple squamous or cuboidal or columnar. But here it's transitional in the bladder because we want cells that are able to stretch, right? As the bladder gets full, it stretches. And as it compresses, these cells can actually get smaller and tighten together. And that's why it's important to have transitional epithelium in the bladder. So again, this is just a general overview of things that they can ask about. They want you to have a basic understanding of the renal system and the renal anatomy. So one of the classic questions that they could ask you from the content we reviewed here today includes a 65-year-old patient who presents to the emergency department with new onset abdominal pain for the last 24 hours. The patient denies any flank pain, but does say that they've noticed a little bit of blood in their urine, which is new for them. Upon further history, you learn that the patient has actually been on a weight loss diet for the last 2 weeks, and they've lost 22 pounds in the last 14 days. The question might then go on to ask you what anatomic structure is actually being affected in this patient. And the answer here is likely to be the left renal vein. It's likely being compressed by the superior mesenteric artery because this patient is losing a lot of weight very quickly. 22 pounds in 14 days is quite rapidly, and the new onset abdominal pain can be due to the compression of this vascular structure. So just a quick summary for this video. High yield anatomy is really what I want to discuss here. We're talking about the basics, including the renal cortex, the renal medulla, knowing some of the arterial supply, including the afferent arteriole, the efferent arteriole, the peritubular capillaries. The key structures that we use for sodium regulation include things like the macula densa and the juxtaglomerular cells. And some of the key anatomy that they want you to know include knowing that the left renal vein is longer, knowing the drainage system from the gonad, whether it's on the left side or the right side, makes a difference. And then some of these key pathologic structures, including nutcracker syndrome, in addition to some complications that can occur due to the close proximity of the ureters to the vas deferens or the uterine artery would also be important. These are the types of things that can actually ask you questions about on test day.